they're keeping you obese, then your insurance company a lot of times will pay for it because it's better to take care of that rather than the heart issues and the diabetes and all that. It's an insurance issue. It's an insurance issue. So I've been in ahead and seen like begin at like 5'8". And like I'm myself up now, so like okay, here. Go ahead, take it. It decreased my A1C a little bit, and I don't eat as much. So it helps.
Are you ready? 'Cause I'm ready.
I'm ready.
Are you back? Okay. I'm ready. Are you ready?
Maybe physically.
He said, I'll wait.
Do you need like 6, 7 more minutes?
I need to share a video with you.
Okay. Before we move into hematology, any questions about the respiratory stuff that we went over?
What are we focusing
You'll get a blueprint.
The like asthma protocol, do you want us to, well, I guess we should know that, right?
Just know about it. You don't like need to go into details of like certain like the RSS scores or anything like that. Yeah. Okay. All right. So let's move into hematology. Okay. What do you notice about this picture, first of all?
Oh, it's like medical.
Doing some medical play, right? We do this all the time. Okay. Completely irrelevant to the whole like hematology portion. It was just a fun picture. Okay. So we're going to talk about. I think there's only 5 disorders that we're going to go over when it comes to the hematology. Do you have a question?
I did have a respiratory question I had to find here.
Oh yeah.
It was about the reversive drug. Or what how to pronounce it? The monoclonal antibodies that we give for passive immunity against RSV. We're supposed to give it as a sequence dose to newborn.
Oh, so there is a there's a monoclonal antibody. I can't remember what it's called. Do you have it?
Nurse, Evamon, or something like that.
You don't need to know that.
Okay.
There is so for infants who are at like an increased risk for respiratory infections like RSV, so our kiddos who are immunocompromised, they can get an injection that prevents against RSV. Okay, but you don't. That is good information to know, but not a need to know for the test. Yeah. Okay. So with hematology, we're going to talk. I think there's 5 things that we're going to go over. Some of them are not super in depth, so it's very like surface level. We're not going to dive into it a whole lot. Okay. We're going to talk about like priority assessment information for them with alterations in cellular regulation or hematologic or hematologic disorders, interventions that we're going to put in place for them, and analyze like lab data, looking at these in particular. Okay. So we're going to talk about hemophilia A, which is factor 8, right? Meaning what? What is factor 8? It's a clotting factor. That's really all I need you to know, right? It is a clotting factor in the clotting cascade, and without that factor, can they continue the clotting cascade? No, right? So the clotting cascade stops there because they don't have that piece, right? So that is what leads to their bleeding disorder. We're going to talk about iron deficiency anemia, sickle cell anemia, and then we're going to talk about leukemia, okay? That is it. Okay, I will not test you on anything else. These are the disorders that you will need to know for hematology for the test. Okay. Okay, when it comes to hemophilia A, there is a genetic component. You do not necessarily need to know or memorize the genetic component of exactly how it plays out. Just like with cystic fibrosis, there is a genetic component. I'm not going to ask you like if mom has this or dad has this, what is that gonna result in, right? Just know that there's a genetic component to hemophilia A, right? If there is an inhibitor in there, they are the most severe complication of hemophilia. They are antibodies that attack that specific factor in the protein that's being replaced, okay? Ultimately, what this comes down to is that they have an uncontrolled bleeding disorder, right? It takes a lot longer for them to clot and stop bleeding than it would a normal individual, okay? It can cause permanent joint damage. So like where the little capillaries go into the joint spaces, they can bleed into the joint spaces and it can cause damage, right? Because should blood be in that joint space? No. When you're adding extra things in there, does that complicate that space? Yes, absolutely, right? So it can lead to joint damage. So if there is an inhibitor, and it doesn't matter what the inhibitor is, if there is one present and this is what's causing them to have that, we are going to give them an immune tolerance induction. So we're going to replace something that's going to help them clot a little bit better, okay? So if you have a kiddo who has been diagnosed with hemophilia, what is your assessment? What does it look like? Okay, signs of bleeding, right? Bruising, right? Bruises that they can't tell you how they got, right? Right, because maybe they just happened to brush by the table and now their whole thigh is like black and blue, right? It doesn't take much. Okay, so you're assessing for signs of bleeding. What else are you assessing for?
Did you get labs for like the body factors?
Absolutely. All right, so you're gonna run labs. Okay, and it's gonna show you that their clotting time is really long, right? So just like we would test for, for individuals who are like on heparin or warfarin and they're going in and they're getting like their PT and their INR, right? We're gonna do the same thing. We wanna know how long is it taking for them to clot, right? And it's gonna show that they're taking a long time, okay? What else are you gonna assess for? Okay, maybe signs of GI bleeding, right? Okay, what?
Like blood pressure and all your vitals.
Yeah, all of your vitals, right? That's standard stuff. Okay. You're gonna assess their joint mobility, right? If they've got bleeding into the joint space, is it gonna be painful? Are they gonna be able to move their joints around? Right? They might be a little bit restricted. Okay. So then we're going to then provide lots of education for these families, right? What education do you want to provide? No contact sports, right? But what if the kid is active and wants to be involved in things? Okay. Be really careful about it, right? So offer alternatives to those contact sports, right? So really we don't want anything, we don't want like football, soccer, really even baseball we don't want because, them getting hit with a ball. Anything where like there is a increased risk for contact, we don't want them to do, right? The other things like running, so like track and field, swimming, those things would be okay. Really, we just want like low impact as well, right? So the running, depending on how they do with it, might be something they might not be able to do either, right? Or if they're like running cross country and they fall a lot because they're like clumsy, right? That might not be something we want either because we want them to trip over something and then like hit their head, right? So they really just have to be careful. Things like bowling would be okay, although they have to be really careful about not hitting the ball on the back of their leg, right? It has happened, so they have to be. In general though, bowling is pretty safe. Golf would be okay, things like that. Fishing, right? Something where they're not going to have a lot of contact. Okay. These kiddos, so if they do come in and they're bleeding, what might they get? Maybe some PRBCs, maybe just platelets, right? They are going to, we're gonna stop the bleed in some way, right? Whatever factor they're missing, we're going to need to give them to help them clot, right? We need to replace what's missing. Okay, cool? Okay, iron deficiency anemia, right? This is common in kids, or can be common in kids, okay? Is it more common in those who are breastfed or formula fed? In breastfed. Formula has everything they need except what piece? The immunity, right? So formula has everything they need for growth and development without the immune piece, right? Breast milk has that immune piece, but it's also what? It's also very low in iron, okay? There's not a lot of iron availability in breast milk, right? So babies who are breastfed will often need an iron supplement starting at what age? A little bit earlier than that. 3 months. Why?
Because they don't no longer have the iron storage from their mom.
Exactly. They don't have their iron storage from the mom, right? Iron storage starts when? In utero.
I'm flipping through my OB.
Right? You thought you were all done with OB, right? No. We are still pulling some of that OB stuff forward, right? So iron starts being stored in the 3rd trimester, right? So our kiddos who are born premature, are they at a higher risk for iron deficiency? Yes, because they weren't in there long enough to get that iron storage during utero during that trimester, right? Okay. So with iron deficiency anemia, it can lead to things like cognitive delays, behavioral changes, right? We are going to see those kiddos who were born term will start getting that supplement at 3 months. And really they only need to be on it for about 3 months-ish, because what happens? They start eating, right? So they're still gonna have breast milk, but then at 6 months we can start introducing baby foods, right? And baby foods are iron fortified, right? So then they're gonna start getting their iron source from there. So they won't need that supplement anymore.
If they're breastfeeding, what if the mom takes
Not enough of it is gonna pass through. So they will need like a vitamin D or iron kind of combo that you'll see that they get. But they won't start it right away. It's about 3 months. And then they only need to be on it for a little bit until they start taking in the formula. Then they can start taking in cow's milk when?
1 year.
1 year. However, same with breast milk, is there a lot of iron in milk? There is not. So we can actually see that we want, they can get iron deficiency anemia because we're just gonna we give them all sorts of milk, right? Want to have them all. But it has very low iron availability, and then they get full and they're not taking in what they should, right? So for toddlers, cow's milk is good, right? We want them to have it. What type do we want them to have specifically? Whole milk, absolutely, okay? But we may have to make sure that we are limiting how much they are getting so that they are not going to fill up on that and not taking the stuff that they need to supplement their iron, okay? Nutrition counseling might be important for which of our kiddos? Adolescent, females, right? Or those with a uterus, okay, who are on their menstrual cycle, right? We know that adolescents, do they eat real well? No. The food that they eat, is it high in iron? No. Is it high in calories? Yes. It's not high in iron, right? So if if an individual comes, into the clinic and we do diagnose them with iron deficiency anemia, so maybe they've got, they just have a poor diet overall, or they're experiencing like heavy menstrual cycles and they're bleeding a lot, which then could lead to iron deficiency anemia. We might put them either on a supplement and or send them to nutrition counseling for diet changes, right? To make sure that, if they don't want to take the supplement, that they're at least eating foods that are high in iron, to make sure that they're not going to be iron deficient. Cool? All right. What do you know about sickle cell? Okay, lots and lots of pain meds, specifically what? Morphine, opioids. Yeah, absolutely, right? Okay, it's more common in African Americans.
Low oxygen and heat, I think, causes some equivalent to sickle.
Yeah, low oxygen, heat, dehydration, right? A number of things can cause it. So they already have a sickle shape, but they have an exacerbation where they like stick together, right? Because do these sickle cells move through the vessels efficiently? Do they have a higher likelihood of getting stuck? Yes. And if one gets stuck, is another one going to get stuck? And so forth? Yes. So they have a higher risk of complications later on in life, right? So you might see that they have visual changes and organ dysfunction because they're not getting good perfusion to those, right? These sickled cells don't carry enough oxygen to perfuse those end organs. So we'll see that generally by like 45 to 50, they have a lot of end organ issues. So a lot of visual changes, kidney issues, liver issues, spleen issues, okay? It is genetic as well. It is recessive. So both parents have to have it, okay? That doesn't, they have to have either have to have it and presenting with the disease process, or they have to be a carrier, okay? If they don't have either one of those, then they can't pass it on, okay? One of the other complications that they can have is acute chest syndrome. So essentially, they're clotting in their lung, right? And we know if we clot in our lung, it results in what most often? Like a PE, right? Or even death, right? A vaso-occlusive crisis is what we call it. So either in the periphery or in the lungs. So if it's in the lungs, it's acute chest syndrome. There is a higher likelihood that they will not make it. Right? There's a higher death rate once they have one of those. Okay.